Okay, this is continuation part 2 of talking about model of healthcare delivery, and we started or we took the view of analyzing the models based on the financial aspect, the division between three different entities: patient, provider, and payer or insurer. Okay, this part we will discuss into depth what are the types of reimbursement. What is meant by reimbursement? Reimbursement is the healthcare term that refers to compensation or repayment of healthcare services. So hospitals provide service, then they get paid. We call this reimbursement. There are three characteristics that we can consider to analyze different types and methodologies of reimbursement. The first character is the unit of payment. Um, um, so, what do we consider the unit of payment? Do we consider anything that I provide as a service unit of payment, or do I consider I consider a package, a complete package of service as the unit of payment? So you may look at it or you may imagine for now there is a type of payment that is called fee for service. So if I do a blood test, CBC test, I get paid. If I do X-ray to patient, I get paid. If the patient comes to clinic visit, I get paid. So this is called a fee for service. So the unit of payment is a single incident of service that I provide. On the other hand, on the other aspect, on the contrary, the unit of payment can be a complete package. So the whole package, patient is admitted for appendicitis, for appendectomy. In this admission, the patient has many blood tests, has some imaging, had operations done, OR time, might need ICU care, hospital admission, etc. But I don't get paid for each of the service. I get paid for the entire package. So this is the first characteristic. We will discuss in more details these types of reimbursement. The second characteristic is time orientation. Do I get paid after, as a provider, do I get paid after I provide the service? This is called retrospective payment. Or do I get paid before even I get to treat people? So this is prospective. The third character is the degree of financial risk that I need to carry or take, which means the level of uncertainty related to cost of healthcare or potential financial loss of or harm. So we will discuss some types of reimbursement that has been really applied in reality. And when we go through these different types, you might imagine progression of reimbursement as issues appear. So we try to solve issue by inventing a new method of reimbursement through the years. So let's repeat what I said. Let's consider this point now. We may say that there are two main types of healthcare reimbursement methodology. So as a hospital, I can get paid in the first type, fee for service. Whatever I provide, I get paid for. The second type is what I described earlier as a package. The correct term for it, the proper term is episode of care reimbursement. So there is an entire episode of care that I get paid. So it is lump sum payment for a complete service. that might include many different things like lab work, imaging, pharmacy, admission, etc. Of course, under each of these, there are different types of payment, and we will discuss almost all of them in some details. Fee of service can be considered as self-pay. So this is the simplest way of fee for service payment. If I don't have insurance, and as a person, if I get sick, I go to ER, I have to pay. I need to do some blood work, I have to pay. I need to do X-ray, I have to pay. I need to do CT scan, I have to pay. I need admission, I have to pay. So this is the simplest imagination of fee for service. Then there are also other fee for service, the traditional retrospective payment. We will discuss this shortly. And came out of this the term managed care. We will discuss it. This term might not mean a lot now, but we will discuss them. The episode of care can be capitated payment, global payment, and prospective payment. We will discuss these types. So fee for service reimbursement, fee for service reimbursement methodology that provide payment each time a service is provided. It is based on either cost or price, what is termed here charge based. So it is cost based or charge based. Cost based reimbursement, fee for service reimbursement method based on the cost incurred in providing services. There is usually a list of services, and for each service there is a number of cost that I need to pay if I get this service. Charge-based reimbursement, a fee-for-service reimbursement method based on charges, which is really the price that the provider has put to give this service, to provide this service. It's similar to a menu that you get in a restaurant. For each item there is a price. So this is charge-based reimbursement. Charge master, provider official list of charges, which is the price, essentially the prices for goods and services rendered. People who have health insurance that reimburses on the basis of fee for service have the advantage of great independence. Why? Because whatever I get, I can choose, and the insurance company has to pay. So there is flexibility for the patient, for the beneficiary. I benefit a lot because fee for service, it means whatever I get, the insurance will pay, and in some aspect I have the choice what to get. So there is flexibility. There is more risk on the insurance, on the payer, in the fee for service reimbursement. For the patient, the disadvantage of fee for service is that fee for service plan often have higher deductible and co-payment. Insurance company try to reduce the risk by putting a co-payment or by putting a deductible on patient. So if I get a payment, I just said I have the choice and I have flexibility. However, insurance company usually ask me to do co-payment, so I pay a percentage, for example 10% of any service that I receive. Or deductible. Deductible is a minimum fixed amount of money that I have to pay for any service I get. By doing co-payment and deductible, insurance company tries to really reduce their risk and distribute some of the risk on the patient himself. For health insurance plan, fee for service has the disadvantage of uncertainty. As health insurance company, they might pay more than what they get. So there is uncertainty and there is higher risk on the insurance company. Cost will increase if the provider increase the fee for each service, if patient receive more service than expected. So this is part of the uncertainty that insurance company needs to handle for this type of reimbursement, the fee for service. I just mentioned earlier the self-pay, the simplest imagination of fee for service. If I don't have insurance plan, I pay for anything I get. A self-insured plan. A self-insured plan is one of which the employer administers its own health insurance benefit. So in this type, let's say I have a company and I have 1,000 employee. So instead of going to insurance company and buying insurance, I create my own insurance coverage in my own company. I create a new department, let's say, in my company, which I call health insurance. And this department is responsible for coverage of health insurance. So this is the self-insured plan. It in one way it is similar to self-pay for a person. If I am individual and I don't have insurance plan, I go and pay for my insurance. So self-insured plan are companies who pay for their employees. The traditional retrospective payment is the one that you might imagine. Retrospective payment, it means that the payment is done after the service is received. Let's go back to the example. I have a company, I have 1,000 employee, then I go to insurance company, I buy insurance for the employees, 1,000 member. And if any one of those employee gets sick, he goes to hospital, receive treatment. After the treatment has been provided, the hospital send claim to be reimbursed, to get reimbursement. So this is the traditional retrospective payment. You can imagine what issues in in fee-for-service reimbursement. As we mentioned, there is increased risk on the insurance company. If the hospital decide to increase the price, the fee, in the middle of the year, the insurance company has to pay. So there is even more risk. So there are different types that has been implemented in reality, created to really deal with issues of fee for service. And these terms that comes here are like different types of fee for service that improve some of the issue or deal of some of the issues with fee for service reimbursement. What is called discounted fee for service payment, UCR, stand for usual, customary, reasonable. It is private insurance. It is based on data from past claim, but it pays for the usual, customarily, and reasonable service. So, for example, if a patient gets sick, he has appendicitis, and he goes to hospital, he receives treatment for appendectomy. What is the usual blood work that is done in this case? What is the customary imaging, X-ray or CT scan that is usually done in this case? What is the reasonable management? What is the usual, the average hospital stay expected? So insurance company tend to cover only in this discounted fee for service payment. Insurance company tend to pay only for the usual, customary, reasonable service. If they found out that the hospital provided imaging unnecessary for this patient who has appendicitis. For example, they did MRI of brain, which does not sound reasonable for a patient of appendicitis. The insurance company does not pay for this. So this is the meaning of usual, customary, and reasonable. Similar to this, CPR is customary, prevailing, reasonable, and usually it is a term from the Medicare that has been used in the past. In our discussion, I might explore more about Medicare and Medicaid insurance plan, which is the system that is used in the United States. RBRVS stand for Resource-Based Relative Value Scale. Let's say a patient was admitted for appendicitis. He received treatment, appendectomy was done in hospital A. Then another patient went to hospital B, which is a different hospital. He received, he has also appendicitis. He received the same treatment, appendectomy done with similar hospital admission. However, does the cost of hospital A to provide the service is similar to the cost of hospital B? This is not necessarily exactly the same, because the facilities might be different. Hospital A might be different from the structure, facility, level of care from hospital B. So we need to adjust for this. We cannot assume that the cost of treatment of appendicitis is exactly the same. So this is what this plan consider. It consider resource-based, and it is relative. So based on the resource that you use, the price or the charges is based on this. So if you go to a clinic and you receive some kind of treatment, it's different from going to a tertiary hospital where the facilities and the machines are expensive and the resource are more expensive. So they cost more, even though you may receive exactly the same service, the same treatment. So resource-based is a payment method that classifies health services based on the cost of the providing physician services. So really it depends on the provider. Practice expenses, or there might be large overhead cost because of the facilities that has been used. Some other costs like malpractice insurance. Okay. Managed care. The term managed care is another type of insurance plan based on the fee-for-service reimbursement model. How it is done, as the term describe it, it is a management of a certain condition with expected outcome. So third-party payer manage the cost of health care and outcome of care, as well as access to care. Usually it is like a team, a program that manage, for example, certain chronic disease like diabetes. So managed care is an entire program to deal with chronic condition. There is usually primary care physician, PCP, primary care physician, who coordinates the care. This plan include educate patient and provider about preventive care. So there is more shift and focus on prevention. There is more focus on quality with assessment of quality and control of the cost. The purpose to reduce the cost of healthcare and ensure better quality. Types of managed care include HMO, PPO, POS. These are different types. I might not get into really details of these. You may read a little bit. I find that spending a lot of time describing. You may read this slide and I might discuss them more in our discussion session. The types of managed care. For the time, I will just move on with this. We might discuss them in our session. So, to just conclude about this type of payment, the fee for service, some experts contend that fee for service reimbursement inappropriately inflates the cost of health care because the payment method reward provider for more services, whether or not these services are warranted. So, the most benefit, in another way, what they are trying to say, the provider, the hospital, they benefit more if they provide more service, even if it is not necessary. So this result in increased cost of health service overall. The common feature in managed care plan is that the insurer has a mechanism by which it controls. So the idea of managed care is really to put some supervision, some monitoring that hospital do not do unnecessary services. So in managed care, insurer has mechanism by which it controls or at least influences the patient utilization of services. So at this point, we finished the first category of reimbursement, the fee for service. Let's move to the second type, which is what I described as package of care. The proper term is episode of care reimbursement. In this type of reimbursement payment method, where a provider receive one lump sum for all the services. So if a patient is admitted to hospital for appendicitis, the hospital receive a total amount of money to include that covers the entire service, regardless of what is really done. They don't charge for each blood test or for each imaging study. There is only some amount of money that is given to the hospital that provide this service. So in episode of care, the fundamental difference is the unit of payment. The unit of payment is not the service, the mere service. It is the entire package, the entire episode of care, not the service. It eliminates fees or charges, so there is no necessary fee for each item that the patient is received for each service. There are three main types of episode of care reimbursement plans. The first one is called capitated payment. We will discuss this shortly. Global payment and prospective payment. The capitated payment is easy to imagine. Third-party payer reimburse provider with a fixed per capita. Per capita means simply per person. For example, we make a contract with a hospital to covers 100,000 people, and we pay, for example, 100 for a person. So this is per capita. So 100 times 1,000, this is what the hospital receive, the amount of money that receive. So per capita means per head or per person. It may be per month, per member per month. The amount paid, the amount of money paid each month for each individual enrolled in the insurance plan. This is a typical characteristic of HMO. We mentioned earlier. We skipped going into details of HMO and other types of insurance plan. We may discuss it in our session discussion session as well. Volume of patient and or intensity of service provided has no effect on payment. So if the hospital provide, for example, more blood test or more x-ray, they will not get more money because the amount of money is fixed. It is episode of care per capita. So you can imagine what advantages in this type of payment. The advantages: the third party payer has no uncertainty. If I am an insurance company and I have 1,000 people to insure, I pay 100, for example, $100 per a person. So 100 times 1,000, this is it. Insurance company, they don't have a risk because they know what they get and they know what they pay, and there is no changes, no surprises, no something unexpected. However, the provider assume really the risk. The provider has a guaranteed customer base. This is one of the advantage. For a hospital, whether they provide service or they don't provide service, they will receive money to cover that covers 1,000 people treatment. Nobody might get sick, so the hospital just receive money for service that they don't provide. So this is one of the advantage. Okay, the second type of episode of care reimbursement is global payment method. Third party payer makes one combined payment to cover the service of multiple providers who are treating a single episode of care. So in this plan, it's not one hospital who provide a service. There might be clinics, primary care, and hospitals in addition to nursery care, in addition to home health care. So the insurance company deal with the service as one altogether. They don't pay hospital separate from clinics, from primary care, from nursing home, from home health care. They pay one payment, so that's why it's called global payment. Although there are many providers, but all the providers share the same amount of money. This method consolidates payment. There are many different versions of this method. Global surgical package, or OB care, cardiac bypass procedure. So you can imagine, for example, in cardiac bypass procedure, it is not only surgeons who provide care. There are ICU care, there are cardiology, there are after surgery rehabilitation, nursing care. So there are really multiple providers, but they share the same amount of money in global payment method. The third type of episode of care reimbursement is called prospective payment. So as you imagine, we are coming to the, it seems that from our discussion, we are moving from the old method to the most recent method. Each method is trying to deal with issues that has arise in the future, in the past. So we deal with it by creating a different type of reimbursement. So relatively prospective is what is used now. It is payment rate of healthcare services are established in advance prospectively. Providers can lose money or make money. They receive the amount of money, but they don't know whether they will spend more money in providing care or not. There are two different types of prospective payment method. per dime payment, which means a daily rate. So third-party payer reimburse provider a fixed rate for each day a covered member is hospitalized. So this type of payment consider the time character. For example, if the person is admitted for 5 days in hospital, the hospital receives certain amount of money for each day of hospitalization. The other type is case-based payment. Provider receive a fixed pre-established payment. How this fixed payment is calculated? For example, Medicare uses the inpatient prospective payment system for hospital inpatient reimbursement. The amount of payment is determined by the inpatient Medicare service diagnosis related group. You might have come across this term before, diagnosis related group. So I would say this is what we consider as a package. A diagnosis that the patient received, and he is expected to receive certain service, and according to this there is expected cost for treating this patient, and the hospital receives certain amount of money based on this diagnosis related group. Okay, new trends in healthcare reimbursement. There is a trend of more dominance of governmental payer to control the cost. If there is no control of the cost, the hospitals might increase the service unnecessarily, and this result in increased cost. And insurance company have to respond by increasing the insurance plan, how much they charge people. So at the end, we will have uncontrolled increase in cost. So one of the noticeable trend that governments are trying to control the cost, and there is more dominance of governmental payer in this aspect. Constantly increasing health care spending. So there is, we discussed this before, the cost of healthcare is increasing every year, and we need to really consider this, and we create methods to control the cost of healthcare. These are some of the relatively new methods of reimbursement that tries to control the cost. For example, value-based plan. Value-based plan is an approach, new approach to provide a reimbursement that rewards the quality rather than the quantity of care. So in this method, there are certain goals that providers need to achieve in the treatment, and these goals based on quality parameter. If the hospital achieve these goals, they receive extra money. This is how it was done initially. So value-based plan or purchase is extra money that the hospital receives if they achieve quality goals. If they don't achieve quality goals, they will not get this extra money. Quality-based clinician compensation. Clinician can earn additional compensation based on quality of care they provide. So there are certain criteria of quality. If the clinician in their clinic achieve, they receive more payment. Shared saving programs. Under shared saving, if a provider reduces the total healthcare spending for its patient below the level that payer is expected, the provider then rewarded. So let's say the cost of providing services is for the entire year, for example, is 100 million. If the hospital manages to provide the same services for less money, instead of 100 million, they provided the same service for 90 million. So they saved 10 million, right? They receive part of this 10 million as incentive that they reduced the cost. Okay. So with this, we end the section of talking about the insurance and the type of reimbursement. And really quickly, I will go over accountable care organization, which is important from one aspect, because we are implementing this model of care in our country, the accountable care organization. So what is the story behind this? In 2010, following the Affordable Care Act, accountable care organization arises as a model. It's a new model of healthcare delivery that tries to control the cost. Accountable care organization is really contracts between different partner or group of healthcare provider, including hospital and primary care. Let's say in one city, one hospital or two hospital with 10 specialty clinics with 20 primary healthcare center. They come together and they contract between themselves as partner, and they are now responsible about managing or treating a population in the city. So the insurance company, the payer, will not have to deal with each provider separately. He will deal with them as one entity because all of them are partner. They will share the money, and they will share the care. ACO is committed to provide integrated health care. One of the main benefits of ACOs is providing a better integrated care. So if patient receives some service in one hospital and is transferred to another, the record is known and relatively trusted, and the patient does not have to repeat work that has been done to him before. So it is better integrated care with responsibility for the cost. All partners in this contract are really responsible for the care of the patient and for the cost of the treatment. ACO typically, when it was first established in the United States, reports 33 quality measures that has been divided into 4 domains: patient experience domain, care coordination domain, preventive medicine domain, at-risk population domain, including chronic diseases. So in what this slide shows, that there are quality measures that ACO is responsible to calculate, record, and provide. So they need to take care of the patient experience side, the coordination of care, the prevention, and the chronic diseases. Okay. With this, I will stop here, conclude the session, and I will leave you with the task. Please read it, and we will discuss it in our discussion session. Thank you very much.